Okay, let's unpack this. We are diving into what you could call the body's core control center, the pituitary gland, and, the drugs that interact with it.
Right. And if you're trying to get your head around pharmacology, this area,
Uh,
wow, it can feel like a lot.
hmm
Hormones, target organs, those feedback loops. It's
It's
complex.
really overwhelming.
So our mission today, let's try and give you that fast track. We want to distill the really essential stuff from this chapter on pituitary drugs.
Yeah, move beyond just listing things and get to the why. How do these drugs actually work to fix things when that control panel goes wrong?
Exactly. How do they restore that stability? That's the key.
And that idea of stability brings us straight to the neuroendocrine system.
That critical link,
Yeah.
right? The brain, specifically the hypothalamus and the pituitary gland.
They talk to each other using hormones, these chemical messengers,
Okay.
making sure everything from growth to stress response, water balance stays in check.
And the mechanism running the whole show is that negative feedback loop. Think of it like a really smart thermostat. The hypothalamus sets the target hormone level.
Right.
If the downstream effect, let's say hormone Y, gets too high,
Hypothalamus senses it.
instantly,
Yeah.
and it cuts back on its initial signal, hormone X. It's all about maintaining balance. Every single drug we're going to talk about is basically trying to either restore that loop or sometimes intentionally interrupt it.
Okay, so structurally then, the pituitary isn't just one thing, right? There's a division of labor.
That's right, yeah. Two main parts. You've got the anterior
The
pituitary.
hormone factory.
Good way to put it. It actually makes and sends out 6 major hormones, things like growth hormone, GH, ACTH, TSH.
Okay. And the other part
That's the posterior pituitary. It's more like a storage unit.
doesn't make its own stuff.
Nope. It just stores and releases 2 key hormones made by the hypothalamus. Antidiuretic hormone, ADH, and oxytocin.
Gotcha. So pharmacologically, why does this division matter so much?
Well, it boils down to 2 main uses for these pituitary drugs. Either it's replacement therapy, the body isn't making enough of something, so we give it back, or they're used as diagnostic aids to help figure out why someone's hormones are out of whack in the first place.
Right. Okay, here's where it gets really interesting. Manipulating those anterior pituitary hormones. Let's start with growth hormone, GH. What happens when there isn't enough? Like in a hypopituitary dwarfism,
That's where somatropin comes in. It's basically a lab-made version of GH.
a mimicker.
Exactly. It mimics the natural hormone. Its main job is stimulating those anabolic tissue-building processes. That's what drives linear growth in kids.
But it's not just about height, is it? You mentioned metabolism,
Right. It's definitely metabolic, too. It triggers glycogenolysis in the liver.
meaning it raises blood sugar,
Yep. And it mobilizes fats, so it has wider effects.
which perfectly explains the side effects then. If
Yeah.
it affects sugar, you've got to watch for hyperglycemia, maybe hypothyroidism too.
And hypercalciuria. But what's the one interaction you absolutely need to flag with somatropin?
Glucocorticoids.
Bingo. If you give glucocorticoids at the same time, they actually reduce the growth effects you want from somatropin.
So they work against each other. That's a big clinical point.
Huge. You really need to manage that carefully.
Okay, let's switch to ACTH, the hormone telling the adrenal cortex to pump out cortisol. The drug mimicking that is cosyntropin,
Wow.
cortisone,
Yeah, and this one has a very specific singular purpose. You really need to lock this one down.
which is
Diagnosis only. That's it.
really just diagnosis.
Just diagnosis. You give cosyntropin, it stimulates the adrenal cortex, and then you measure the cortisol response. If cortisol doesn't jump up like it should.
And the patient has adrenocortical insufficiency.
Exactly.
Ah.
But, and this is key, we treat that insufficiency with replacement steroids, not cosyntropin. Cosyntropin is purely for the diagnostic test itself.
Got it. Test, not treat. Okay, now let's flip the script. Instead of mimicking, let's talk about antagonizing or blocking. The drug here is octreotide acetate, sandostatin.
Right, so instead of acting like GH, octreotide acts more like the body's natural inhibitor of GH, which is somatostatin. It blocks GH release.
But its uses are, well, they seem kind of diverse and maybe unexpected.
They really are. It goes way beyond just blocking GH in conditions like acromegaly. Octreotide is a real workhorse for some pretty extreme GI situations.
Like those rare carcinoid tumors, the ones that secrete VIP?
Exactly. Those tumors can cause just awful relentless diarrhea, flushing, and sometimes this life-threatening low blood pressure called a carcinoid crisis. Octreotide helps manage those symptoms.
Okay, that's one major use. What's the other big one?
The other is emergency management of actively bleeding esophageal varices. You see this in patients with advanced liver cirrhosis. It's a critical adjunctive agent in that scenario.
Wow. So from a rare tumor to a major GI bleed, that's some serious versatility.
It is. But with that versatility comes significant risk. We need to talk about the downsides.
Right. What are the big red flags for adverse effects?
Well, ironically, while it treats one type of GI crisis, it can cause others. Severe diarrhea, nausea, vomiting, those are pretty common.
Okay, but what's more serious?
The cardiac effects. It can cause significant conduction abnormalities. That means you absolutely need a baseline ECG before you even think about starting this drug.
Mandatory ECG. Got it. Anything else?
Yes, blood glucose, it can mess with it significantly. You might see severe hypo or hyperglycemia, so extreme caution is needed, especially if the patient already has diabetes.
And there's an interaction note too, right? Ciprofloxacin.
Good catch. Yes, Cipro can actually worsen the QT prolonging effect of octreotide, so that doubles down on needing that heart monitoring.
Okay. Extreme versatility, but demands extreme vigilance. Makes sense.
You got it.
All right, let's shift gears now. Let's move to the posterior pituitary drugs. And the main player here is the hormone-controlling water balance, ADH.
Antidiuretic hormone. Its job is pretty straightforward. Concentrate the urine.
How does it do that?
It acts on the kidneys, specifically the nephrons, telling them to reabsorb more water back into the body. Up to 90% of the water siltrate, actually.
So if someone doesn't have enough ADH?
They develop diabetes insipidus. Now, this has nothing to do with blood sugar diabetes.
Right, different condition entirely.
Completely different. It's characterized by just overwhelming thirst, polydipsia, and peeing constantly, massive amounts polyuria. Leads to severe dehydration if it's not treated.
And to treat that ADH deficiency, we use two main drugs.
Yep. Vasopressin, which is essentially synthetic ADH, and its close relative, desmopressin, they're both ADH mimickers, used to control those diabetes insipidus symptoms.
But there's a critical difference between them, isn't there, based on a small change?
Ah, yes.
Yeah.
This is the really high yield point. Desmopressin is like precision ADH.
Precision. How so?
It has 10 times the antiuretic effect of vasopressin, so it's great at stopping the excess urination. But, and here's the key, it has way, way less vasoconstrictor effect, like 1/1500th less.
Okay, so it doesn't squeeze blood vessels nearly as much.
Hardly at all, relatively speaking.
Yeah.
This makes desmopressin the go-to for straightforward diabetes insipidus. It's also useful because it boosts factor VIII and von Willebrand factor.
Which helps with certain bleeding disorders.
Right. Mild hemophilia A, type 1 von Willebrand's disease, and it's also used for bedwetting nocturnal enuresis in kids over 5.
Okay, so that's desmopressin. Precise water control, minimal blood vessel effect. What about vasopressin then?
Vasopressin is the opposite, in a way. Because it is such a potent vasoconstrictor at the doses used, well, you don't really use it primarily as a water-regulating drug. You use it as a shock agent.
To clamp down blood vessels.
Exactly. You use vasopressin when you need serious vasoconstriction. Think septic shock that isn't responding to the usual drugs like epinephrine or norepinephrine.
Yeah.
It's also listed in ACLS guidelines as an option during pulseless cardiac arrest. And like octreotide, it can be used for certain types of GI hemorrhage, including those esophageal varices.
Wow, so one tiny tweak to the molecule changes everything. Desmopressin is for water balance and mild bleeding issues, while vasopressin is okay. And for somatropin, we know it affects metabolism.
So you monitor thyroid function, calcium levels, and glucose, because you're watching for potential hypothyroidism, hypercalciuria, and hyperglycemia.
And in kids, you mentioned paying close attention to growth and motor skills.
Absolutely. Something like a limp could signal a serious bone issue developing, so you need really careful assessment.
What about desmopressin?
Need to know if there's a history of seizures, asthma, or cardiovascular disease. It can potentially worsen those. And obviously, if you're giving vasopressin for shock, that's continuous ECG and vitals, no question.
Makes sense. Now, administration. These aren't simple pills often. Teaching is key. What about somatropin reconstitution?
Ah, yes. Crucial point. When you mix the powder and the liquid, do not shake it.
Why not?
Shaking damages the protein structure, makes the drug useless. You have to use gentle swirling only. And like other injections, rotate the subcutaneous sites.
Okay, gentle swirling. Got it. What about intranasal desmopressin? Any special instructions?
Definitely. First, the patient has to clear their nose out before using it.
Makes sense.
And the pump needs priming. The very first time it's used, you press it down 4 times. After that, it stays primed for about a week.
And if the dose needs to be split?
Half goes in one nostril, half in the other. Patient needs to understand that.
Okay. And a general point for anyone on desmopressin for diabetes insipidus fluids.
Huge issue. You have to stress monitoring water intake.
Yeah.
Because the drug is making them retain water. If they drink excessively on top of that, they can get water intoxication, wash out their sodium. It can be dangerous.
Good point. And finally, always be aware of those look-alike, sound-alike drugs. The example given was sandostatin octreotide versus sandamine cyclosporine. Easy mistake to make if you're not careful.
A potentially devastating one. Always double check.
So how do we know these drugs are working? Evaluating the effect.
It's usually pretty direct. For octreotide in carcinoid syndrome, you look for improvement. Less diarrhea, less flushing.
So for desmopressin or vasopressin in DI?
You want to see decreased thirst, decreased urination, less polydipsia, less polyuria.
And for somatropin in kids?
The most obvious sign? Increased growth. Following that growth curve.
You know, this whole deep dive really hammers home just how potent this relatively small neuroendocrine system is.
Absolutely.
Whether we're mimicking GH with somatropin or using cosyntropin just for a test or blocking hormones with octreotide or tweaking water balance with ADH drugs, it all comes back to that delicate feedback loop.
It really does. And the core idea is always trying to get back to stability. If you can really understand the why, what's deficient or what's in excess, then the drug's action just clicks into place. It makes sense.
All right.
Which I think raises a really interesting question for you, the listener, to think about. How can a problem in such a tiny system, like a lack of one hormone like ADH, cascade into such massive, potentially life-threatening symptoms all over the body if you don't treat it?
That's a great question. Really highlights how interconnected everything is.
So keep diving deep. We really appreciate you joining us for this look at pituitary drugs. From the whole Last Minute Lecture team, thank you for listening.